Good evening, everybody. Welcome to our fifth webinar on in the Cirrhosis Care series, practical tips you can use in your practice. My name is Panita Tandon. I'm an associate professor of medicine and co-director of the Cirrhosis Care Clinic and transplant hepatologist at the University of Alberta in Edmonton. I'm also a medical director for the Office of Lifelong Learning and the Physician Learning Program. The Office of Lifelong Learning is committed to providing the latest information, advice, and resources related to cirrhosis care for physicians and other healthcare providers. Just before we begin, I would like to acknowledge that we are on traditional territories across Canada of the many First Nations, Métis, and Inuit, whose footsteps have marked these lands for centuries. So with that, I am thrilled to introduce Dr. Amanda Brisebois, who is a close friend, and she's here tonight to share with us on palliative care and cirrhosis. It's not just end of life. Now, a little bit about Amanda. She's an active member of the internal medicine community. She's been an attending physician at the Grey Nuns Hospital inpatient medicine unit since 2000. She graduated from the University of Calgary. And after attending a first year of residency at the Mayo Clinic in Rochester, she returned to Canada to complete her internal medicine residency, a year of oncology training at the U of A as well. And after experiencing multiple years of helping patients live with chronic illness, she returned to do a year of added competency in palliative care, which she completed in 2012 in Edmonton. With that, she spent 2012 and 2013 working on the palliative care consult service at the Royal Alexandra Hospital and at the Palliative Care Unit at the Grey Nuns Hospital. She's focused on helping non-cancer patient populations live well with better symptom control and understanding of how disease progression impacts a patient's life. And I hope that she'll tell us a little bit about the clinic that she founded, PPRISM, which is a non-cancer palliative care outpatient clinic located in the Kaye Edmonton Clinic. She's got adjunct appointments in palliative care and in the Division of Internal Medicine, and she is an active and passionate participant for caring for patients in both of those domains. And with that, Amanda, please take it away.
That was an amazing introduction, as always. Thank you so much, Panita, and happy evening to everybody in this cold, cold weather for those of you in Alberta. I love this topic. I love talking about palliative care and non-cancer illnesses, and we'll focus a bit on cirrhosis, but it really overlaps with all of the patients that you'll be seeing with non-cancer illnesses. And even most of this is pertinent to those with cancer as well. So I have no disclosures to add, and I always like putting this slide right off the bat because it just gives you a good indication of a lot of the misconceptions that palliative care, that terminology has, and even some of the people I've worked with really closely for years and years still say to me, well, you know, you just deal with the end of life. And I keep trying to reiterate that that's not really the case. So the objectives for tonight, I really want to talk a little bit about this term palliative care, how it relates to chronic illness and cirrhosis, particularly understand our roles as practitioners with cirrhosis care and with respect to these palliative care principles. I also want to talk about the chronic illness trajectory when we start advanced care planning conversations, and in Alberta, as we say, goals of care designations, and why that's so important. And also reflect on the components that contribute to symptoms and treatment principles. I also want to introduce the website that Dr. Tandon and a group of us have so passionately been working on, which will be launching very soon, early in March, will be a great resource for all of you on the call who will be able to access some of the more detailed approaches to symptom management in cirrhosis care. So just to talk a little bit about my journey, not that I like talking about myself, but I do think it's a really interesting way to talk about chronic illness. So when I did general internal medicine on its own, lots of years of experience with that. I'm going on to my 21st year as a general internist. I saw so many patients, as many of us do, with chronic illness who come into the hospital. They have symptoms, they go home, they go into the community, get care, still have symptoms. They have lots of worries and concerns, come back into the hospital, and this cycle of care when someone has a chronic disease. I remember one day in the emergency room, and this was before I decided to do palliative care, I saw this lady with COPD, and she'd come in and out over and over. And in internal medicine, we do 1 week on service at a time. So I would be on probably 2 weeks a month, usually separated by a week or two in between. And it was about 2 in the morning, and I went down and I said to her, "What are your expectations with this? I keep seeing you here in the hospital." She's very short of breath, can't breathe, very frail lady. And she said, "What do you mean? What are you talking about?" I said, "Well, what do you know about your illness?" She's like, "Well, I don't know what you're talking about." So, "Well, what are your expectations of me as your physician when you get discharged?" And she goes, "That's the stupidest question I've ever heard. I'm going to be better." And I said, "Well, what does better mean to you?" And she goes, "I'm going to be better. I'm not going to have any symptoms. I'm not going to be short of breath. I'm going to be walking normally." I'm like, "Well, what is normal?" Like I did before I got sick. And I don't know what about this lady, but I wish I could thank her, because we'll never forget that light bulb moment that she has no concept that she's going to be short of breath for the rest of her life. And nobody's talked to her about what the possible implications of that are. And she expected to come in and we would just fix her and she'd all of a sudden be normal, which she never was. She always felt a little better because she had care all around the clock. So it really made me wonder, what is this thing? What is this specialty, or is there a specialty? And I always thought of palliative care as hospice care, to be honest. I mean, that's a lot of years as a specialist, and I always feel a little embarrassed by it now. But I thought that when I consulted palliative care, it was when I needed hospice placement. Never, ever crossed my mind that I would consult palliative care for symptom management. Did not cross my mind. I thought I was really great at using opioids, and now I know definitely better. I just was never trained in that area. So I do love having made the transition, because now I was a person, didn't have a lot of training in it, and now I can try to promote people just continued learning. And so I'm so happy that you're all here tonight doing that as well with me. So I just took over the medical director role at the Palliative Care Institute for Covenant Health, and I'm super excited about that work. It's really going to overlap with this chronic illness care that we're doing. And being the medical director at the Grey Nuns is also great, because I try to promote these things throughout the sites. So what exactly is palliative care? And as I was alluding to, it's not just the end of your life. And I always say to the patients, your death is not part of your life, really. Your death is the end of your life. So what's most important is, how do you live your life, and living a great life? And that's what palliative care is about to me. And so I had a cardiology patient in my clinic. He was around 65 years old, terrible heart failure. And he kept coming back to my office. And every time he came back, he said, I think this is the greatest thing that's ever happened to me. He said, I tell all my friends I'm seeing this palliative care physician and my life is so much better. And they just can't believe it. They're like, but palliative care means you're dying. And so he was spreading the word that palliative care is about living your best life with the illness that you have. And I just love that messaging. And my patients seem to like it too, because they love knowing that somebody cares about how they are living their life. So who does this care? And I'm so happy to have all of you interested in this, because it's all of us. You do not need to be a palliative care specialist to do this care. We're all doing it. We're all taking care of patients like this with cirrhosis, with other illnesses that are not curable. So we have to sort of figure out how we're going to do it together. And the communication between us as practitioners is really critical. And Dr. Tandon and I, and Dr. DeCock, who's on the call as well, we're always talking about, how do we do this? How does the specialist get their input to the primary care practitioners? And how do the primary care practitioners get heard? And how does the community then integrate that care? How many of you getting a specialist consult back, does it say, this is how the patient is integrating the disease in their life? Or we had a conversation about goals of care, and this is what it said, or talking about prognosis. We need to start putting those things in our communications. And if we don't know it, picking up the phone and talking to each other. There's a lot of work going on in Alberta, these transitions of care. So H2H2H, many of you have probably heard of this, home to hospital to home. But I kind of like to think about it as healthcare to healthcare to healthcare, because some people don't have a home. And healthcare and acute care facilities, there's a lot of different components. We're using information technology. So look at us now, we're sitting here on Zoom having these conferences that we wouldn't have had before. With COVID, we have virtual care options now. We have codes that we can actually get paid to do in Alberta with virtual care. And a lot of this palliative care work is about talking to people and really listening to people. And this is really amenable to virtual care. So there's a lot of ways, and I'm hoping that people will ask questions about this. How do we integrate this into our practices? So advanced care planning discussions, how do we do this? I have a lot of times I talk to residents and they go, oh, don't talk to me about advanced care planning. I know what I'm doing, and it's a pretty straightforward topic. But it is the farthest thing from a straightforward topic. It's extremely difficult. I remember the day I went to work, I hadn't done palliative care yet, and the green sleeve with these goals of care designations had showed up at our hospital. I didn't know what they were. And all of a sudden, I was supposed to fill out this form saying whether my patient was a R, resuscitation, or M, medical care, or C, comfort care. I had no education about it. I mean, we've come a long, long way, but there's still a long way to go. There's some really fantastic resources, and in my clinic, which isn't running anymore, but when it was running, I would give all the patients the information to go talk about these goals of care discussions. And I'll talk to you about one of the strategies that Dr. Tandon and I published. So these are just websites. Speak Up is the national website. Conversations Matter is the Alberta website, and Plan Well Guide is just an amazing guide by Darren Hayland, who's an intensive care doctor in Ontario. And it actually gives the patients printed out materials with questions, and they can take it home and go talk to their families about what's important to them. So one of the things that's so important is having a decision maker. And we've done a lot of work with the legal system in Alberta. And those of you who have a will, I went and looked at mine with my lawyer, and it says, if this happens to me and I'm in a coma, I don't want to be resuscitated. And right now, the legal system is really trying to get away from that and direct people towards the physicians to help them make those decisions in the medical situations. But the legal documents are trying to name a decision maker for you. So this is interesting, some studies I've referenced here that showed that up to 80% of patients in hospital were unable to participate in these in-hospital end-of-life decision-making decisions. And this is a huge, huge percentage. And if you think about cirrhosis and hepatic encephalopathy, even if it's minor, it's very likely that they will not be able to actively participate and meaningfully participate in these discussions. So what happens to non-informed surrogates? And I don't know how many of you in your family are named on someone's will as being the surrogate, but it's tough if you haven't had the conversations. So these surrogates basically guess the preferences for CPR, and that guess is just better than chance, just modestly better than chance. And only 35% of them in these studies correctly identified treatments that the patient was willing to accept. So that's a scary prospect for most surrogates. So informed surrogates work with the teams to make the best possible in the moment medical decisions. And that's what one of these papers says, but it's really interesting because I like to say to the decision makers and the patients when we're sitting in the room together, the beauty and the gift of these conversations now is you do not have to make a decision for your person. You're not telling the physicians what you think they want. You know what they wanted because they had the conversation with you. And having that conversation in front of the patient and the family member, or technically family member, whoever their choice of person is that person feels that they know what they wanted and they know that they're not actually deciding for them. So that's very, very useful. So the lack of advanced care planning really leads to inappropriate care. So when I just had gotten out of the added year of competency, we did this study, and I was thankful that Dean Carvalis got somebody to help do this research. But we pulled the patients delisted for transplant at the University Hospital and found that they really received aggressive care and suboptimal symptom management. And so these were the numbers from that. Only 11% of these patients were referred to palliative care. And that was very in keeping with my experience as a general internist, referring really for hospice care. 48% of them were referred to ICU after being delisted, which is such a huge number. 17% had renal replacement therapy, and only 28% had goals of care discussions, designations. So remember though, this was before the green sleeve. So now, how are we doing? Like, you'd like to think that we're doing a lot better. So the CREO grant and the ACCEPT study led by Jessica Simon in Calgary, it was a great study that I was involved in. We actually did a cycle here in 2017. We involved several hospitals in Edmonton. So a lot of national participants, so 1,400 and around 450 participants in Alberta, looking at the advanced care planning in hospital and how we did. Very interesting. So as far, I can't see this part of my slide, hold on. So only 27% of patients had a concordant goals of care discussion. So that means that whatever was written on the green sleeve actually matched what their wishes were. this was actually a good number across Alberta. Some of the numbers were even lower than that. So that means that even though we're having a conversation and we're documenting what we think the patient wants, the majority of the time it's not actually what they want. And if you look at the lower left-hand corner, it's basically saying that we are actually being over aggressive with what the patient wants. So there are a large number of patients that wanted comfort care, and we actually had medical care management on the green sleeve. So we have a long ways to go still. It also said that patients wanted more conversations, and the more conversations and the more elements of advanced care planning that were undertaken in hospital, the more likely that the patient's concordance was going to be there. So the more likely we're going to get it right, which totally makes sense. So this is out of Dr. Tandon's clinic, and we looked at 100 patients in the clinic with a MELD score, median MELD mean score of 11.5. So this first one, the question was, knowing that you have liver disease, do you feel that this will affect the quality of life in the future? This shocked me. So 48% either were unsure or didn't know. I could not believe that that high number of patients thought that having cirrhosis would not necessarily affect their quality of life. The next question, we had a lot more, but we just tried to pick out the most interesting ones. The next question was, where do you prefer advanced care planning discussions to occur? And almost all of them wanted it to occur in the clinic, which makes sense, although it's not what we do. And the last one, how important is it to know the truth about your health, even if it is not good news? Extremely important, 70%, and very important, 27%. It is amazing how many patients want to know what's going to happen to them. There's a very, very small number that don't. There's a lot of discussion in the literature that having these conversations takes away hope. And there's a lot of literature now that it doesn't. So having these conversations, it increases people's knowledge, it doesn't impact their hope, it decreases their anxiety, decreases issues with bereavement. I remember this one time I brought a resident in, and this patient was dying. He was an elderly man, and his daughter, she was in her sort of mid 40s, was in there and really upset, in tears. And I sat down with both of them, talking to them about prognosis after asking permission, obviously, and wondering if he was worried about the future and what the future held. And both of them really wanted to have that conversation. And they had said nobody had talked to them. And, you know, we all hear that about patients. I have had patients say I never talked to them about something too, and I had, but really it's conversations are in the eye of the receiver. So we can have this conversation multiple times and they still don't remember it well, but it just means we have to talk over and over and really make sure they understand. So I sat down with her for a long time, told the daughter the prognosis. It was very poor. And we walked out and the medical student had a bit of a cry. It was very hard. And then we went home. The next day we go into the room and this daughter was jubilant. She was excited. She was smiling. She had brought her dad some stuff. He was laughing. And the student said, "What's going on?" And the daughter said, "You have just empowered my whole life." She said, "I have so much hope now that I can be here for my dad. I know what to expect." And that terrible conversation that seemed so difficult gave them so much. So this is the wheel that we created. A lot of this stuff is in the literature, but I like this wheel. And Panita and I, when we were driving to Banff one day to give a talk, we thought about this cogwheel thing, because this is not a step-by-step process. We have done the Serious Illness Conversation Guide. I like it. It's got a lot of great sentences to say and a lot of things to say. It is seeming like a stepwise process. And part of the trouble with that is that when you start having these conversations, patients change the discussion, or all of a sudden you get involved in part of this wheel and you're sidetracked and the conversation is half an hour and you need to complete the rest another day. So I actually have created a little card. It's laminated. It has this on it, and it also has the graph that I'll be showing you next. So the different parts of this are very important. So the patient perspective, is it something we leave out? What do you care about? What do you need to know? Who needs to be with you? How do you learn? What kind of information do you want? Are you someone who thinks about the future? Are you someone who likes details? Do you not like details? That's a lot of questions for people. So you may even, those of you in private practice and in primary care probably know your patients a lot better than someone who walks into the hospital and meets an internist for the first time at 2 a.m. But those things are still super important. And then readiness. Are you ready to have these discussions? Because if they're not, when we make someone a medical care in the hospital, they're not going to remember and understand. So education is component. The focus of care, I'll show you the graph, what that means. Prognosis, we don't talk to patients enough about that, and I'll just talk about that very briefly. And then with diseases like cirrhosis, so important that they understand what can happen if they want to know. So many patients want to know what it means if they have black poop, should they actually go call a doctor? Because if they haven't had those discussions, sometimes they won't call the doctor. And so we've created some handouts for patients, educational materials. If they want that information, then they have it. Sometimes the patients don't want to know. They want to live in the moment, but the families want to know because they want to know what to look for. They want to know what to look for if someone starts to get confused, what happens. So there's a lot of things that will be on this website about disease complications, what to look for, and educational materials. The goals of care documentation on the green sleeve in Alberta or wherever you're calling in from, whether you're resuscitative care or medical care or just end of life, keep me comfortable care, that's just the documentation piece. And then every time they come in and out of hospital, you have to review it and you have to recheck all of these things. And you have all of us in the middle here, of course, and the patient at the center. So this is the article that we wrote about it. But I actually put this picture and the graph in people's green sleeves when they go home. And when I go to discharge them, I say to them, hey, do you know what this green sleeve is? I'm going to tell you 95% of the people have zero idea what it is, even though it's documented. So it's always good to readdress things with people. And so prognostication, I'm not going to talk about it a whole lot. I wish I could talk to you guys about a lot of these things in more detail, but always remember this triad of medicine. So therapy, 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 we think about it so much, and how do we make the diagnosis? And we're doctors and we're so good at it. Now I say my internal medicine world is all in here, you know, what can I do? But this whole prognostic piece is really massive. And that really is important to the patients. So we have a lot of different scores we use here in the last weeks of life, but cirrhosis has a lot of great prognosticating tools. And if you're wondering about those conversations with your patient and you're a hepatologist or you're the primary care doc and you want to talk to the other docs about it, put these things in your note and what it actually means. The Cliff SOFA is an ICU score. So there's a lot of great ways to help us prognosticate. So prognostication also includes quality of life and function. In fact, one of the things that really fits into all the palliative scores is function. So when you start to see people declining, they weren't as good in January, weren't as good in February as they were in January, and they were a little worse in March than they were in February, that means that these discussions need to start. So why is it so important to start these things early in cirrhosis? So this is something that was published in a great journal, 2018. You're going to see a lot of things like this. When do you refer to palliative care? When do you start this work? This one is beautifully graphically. It says end of stage liver disease, awaiting liver transplant, not eligible for transplant. They have some hospital admissions, some decompensated disease with ascites, encephalopathy, and their scores aren't so good. But I look at that, I think, have we missed the boat if that's when we start thinking about this stuff? And honestly, I think we have. So this graph is not something that Dr. Tana and I created, but we did make it all colorful with the help of Dr. Patel, who's very good at graphics, made it a little prettier. So this graph, for those of you who have not seen it, is a graph of chronic illness. So this axis is the aim of treatment, or it can be function. All of this green stuff is that stuff we love so much as physicians, the disease modifying therapy, that amazing stuff that you've heard about the last weeks from these other great presentations that have been given in this series. So what can we do to try to control cirrhosis? And at first, when we meet someone, that's the focus. As we start to see them in the clinic a little bit more, they may start to have symptoms. So the palliative principles is all the orange stuff. Symptom control, quality of life. How does this integrate with your life? How are you feeling about having this diagnosis that we can't get rid of? So really currently the conversations are starting here, very end of the disease. I'll show this to my patients, I'll describe it, and then I'll say to them, where do you think you are on this graph? And in hospital, notoriously, they're somewhere in here, somewhere in the middle to near the end. And they'll say to them, do you see these dips? That means you have something happening. Something's wrong. Maybe you have encephalopathy. Maybe you've had a GI bleed. Maybe you've got spontaneous bacterial peritonitis. You've been admitted to hospital. And I say, have you ever wondered if you were going to die when something like that happened? Have you ever wondered that it would go so low that you would die? And they look at me and they go, oh yeah, that was the last admission. And I'm like, huh. When you went back home, were you as good as you were before? And almost always they're like, no. And so I said, oh, so you're telling me that you're living this. And so this education really gives people the idea. And I have story after story of people who've almost died and then they didn't die and they have another bump and they keep coming back to my clinic going, oh, I got through another one. So this can be very empowering for them to know. So we really feel that these conversations should be starting here. I had a young gal with idiopathic pulmonary fibrosis, and I was actually watching exercise clinic, and she just happened to be there. I was discharging her from hospital about 3 weeks prior. I discharged her, and we were in the parking lot. And she said, "What are you doing here? That's so weird." And I was telling her, and she burst into tears. She was probably 27 years old. And she said, "I would do anything for somebody to have talked to me about how this disease integrates with my life." And she was way up here in the disease. So very, very important things. So I really try to bring best and worst case scenarios into conversations. If any of you have not seen these videos by Wisconsin physician Toby Campbell, he does these cartoon drawings about how to explain to patients what's the best case, how are you going to do with certain things happening, what's the worst case if, for example, you have a variceal bleed, what's the most likely situation, and then what's the best and worst case if you don't have something, for example, a transplant. And they've just come out with a new one for nephrology. Great, great idea. Talk about patients with real life scenarios. So I use things like you might have a GI bleed, or I don't obviously use that terminology, but give them ideas, things that really would make sense to them, and use those in the discussions. So early palliative care really improves patient symptoms as well. There's lots of studies out there that are starting to show this. This is a depression score that shows that it gets better with these principles being adhered to, and many, many of the symptoms also will improve. We're really hoping to continue to get more data in this regard, because the more data we have, the more funding we'll get for these kind of studies. So palliative care integration really improves some other things too as well, decreases anxiety, as I said, increases quality of life. And again, we're really trying to start to show some improvement with healthcare utilization, but this is a really tough one because these patients, especially with cirrhosis, they're really sick. We just did a study through the emergency room, and the cirrhosis patients were the ones that were readmitted the most. So they're sick, and even if they know what's going to happen, they'll still probably end up being readmitted. So these symptoms, as I was saying, very high burden, long-term, it's years, not months, and the symptom burden is really high. So lots of pain in these patients. It's probably the biggest symptom that I've seen, and we're so lucky to have Dr. Rashik talking to us next week about pain management. He's done a lot of work on this website with us. Lots of pain from ascites and other things. Nausea, depression actually in a lot of the studies is higher than this. Anxiety, dyspnea from ascites, and lack of appetite and cachexia, as was talked about, frailty, really huge symptoms. So some of you may know this score, but you don't have to use this score to track people's symptoms, but it's something that I really changed my practice going from a general internal medicine specialist to a palliative care specialist. Before I would say, where's your pain? What would you rate it? I really wouldn't get a lot of details. So this is a 10-point score, 10-point scale with different symptoms. This is right now at the moment, 9 out of 10 now, but what happens to it after you get the medication? What number does it go to? What does it happen 2 hours after? What does it happen 4 hours later? What's the worst it gets? What's the best it gets? So if you probably, and I'll show you a screen coming up, but you've probably heard of OPQRST UV for symptoms. That's onset, provoking, palliating, those kind of things. U and V is understanding and, oh, that's so funny, I just forget it, values. So understanding is what actually do you think is causing it, and values is how does it impact your life? So those are really, really key pieces. So somehow do symptom scores to track your patient's symptoms. And this is a great tool to give to your patients in the office before they come see you. They can fill it out, and then you can at least screen which patients have things you need to address. So this was a study that just showed how severe these symptoms were. Over 85% in this study had a score of moderate to severe of more of these one symptoms. And here's another one, many patients on opioids for pain, lots of patients with symptoms over 6 out of 10. Anything over 4 is really determined to be significant. So symptoms are really complex, and non-pharmacological therapies are really important. This is what I was talking to you about, symptom history, taking this OPQRSTUV. And those of you who don't know Fraser Health, .ca resources for palliative care. These are amazing resources and recommendations. I use them all the time. They're PDFs, very simple. They have ascites, pain, nausea, vomiting, a lot of different things. So I highly recommend this resource. So symptoms are complex. And one of the things I talk to all my patients about is total suffering, total pain. Some of you may have heard about. I talk to them about this before I start any treatment, any medications, and explain to them that pain is not only about physical receptor pain. Pain is about psychological issues, social issues, cultural, spiritual, and the physical piece. I always say that's my little internal medicine black box of the receptors. But medications act on receptors. And so if it's not only this, medications won't work. And it's very, very important that patients know that right off the bat. So LEAP is something I just wanted to, because this image came from Pallium or LEAP, but LEAP is an educational program that I think if those of you are interested in more education, we're trying to develop some Alberta guidelines as well, but it's a great resource. And right now have a lot of virtual training if you're interested in more palliative care training. So how do I approach symptoms? As the internist in me, before I did a lot of this palliative care stuff, would I go right to the pharmaceuticals? I'm not going to lie. Yeah, probably did. So someone comes in nauseated, I'm like, okay, I'm going to give them some Maxaran or whatever it may be. But really, it's important to really start here and move through the cycle. Obviously, if someone's in hospital and they've got a perforated something in their abdomen, you're going to give them pain medications. But this is just the general process to follow. So prevention, very, very important in these patients. So as you've heard in the last weeks, optimizing nutrition, minimizing frailty, optimize the disease state as we talked about. Then the psychological, we heard about the multidisciplinary clinics that are in different places. Amazing to try to develop these clinics with social workers and psychologists and what kind of resources can we get. And Dr. Tandon's Cirrhosis Clinic is really working on this model as well. And then the physical piece, as we said, minimizing frailty and minimizing the physical impact of cirrhosis and things like controlling ascites, et cetera. And then the pharmaceuticals. So the pharmaceuticals are really the last step. And when I did my non-cancer palliative care clinic, I often had people walking out with some sort of prescription. And I changed that actually after about a year. I ran the clinic for about 4 years. And I started seeing them for at least several times before I even gave them anything, because there's so much education that's required. It's really the last step. And you'll hear this from Dr. Rashik too, as well, when it comes to pain control. All these other things are really critical. So where do we start? I love these little dinosaurs with Noah's Ark. But have we missed the boat? Did I miss the boat because there I was a general internist for all those years? I could have done things better. No, absolutely not. Like, we've got so much time to do this. We've got motivation to do this. We have resources. We have so many people passionate about this work. So you may feel like you're up here, but really all the fish are around you swimming with you together. So I'll talk about symptom control a little bit. This is another great resource, the Mayo Clinic proceedings. It's a long time ago. I'm not showing you this to show you what medications to use. So the medications are going to be on the website, the ones that we recommend. We've done a lot of work on that, but this is just really interesting because if you go into the literature, if you go to Up to Date, if you even go to LEAP, I was looking at their palliative care handbook the other day, there's stuff in there that may not be evidence-based. A lot of the stuff that we do in palliative care is off-label. For example, Haldol for nausea. It's not indicated in the CPS for nausea. So it's very important to remember that and talk to patients about that. And the thing, if you look at this protocol, so here we have tramadol, it's medications that's used, doesn't mention anything about the fact that it lowers the seizure threshold. I do tend to avoid that in patients who have cirrhosis for that reason, especially they get low sodiums or they have alcohol history, withdrawal history, and that's not really talked about here. Again, gabapentin, it was interesting the other day in one of the talks, one of the specialists was talking about starting gabapentin 300 milligrams TID, which would be fine. You look at what's out there. But in my clinic, a lot of my patients didn't tolerate 100 milligrams starting at night. So I think the messaging that I want to bring and what we're going to bring to you on this website is you really need to know your patient. They're very individualized. Look at what their organs are doing. why not start at the very lowest dose of something and see how it works? I mean, Dr. Rashik always laughs at me because I'm using such small doses of opioids, but I'm fine with that because at least then I know that they're not going to have side effects, and the patients buy into the medications much more once they don't have any side effects to it. So here, let's get everyone together and get a consensus. And this is what Dr. Tandon has done so beautifully. I give so much credit to her. We came up with a lot of these ideas, but she ran with it and got a big grant for it and has really brought our communities together to start coming up with these guidelines. And I just think it's a great partnership for me, but I think it's a great partnership for our patients. So thank you to all these people on here. And I'm sure there's many, many more that I've missed, part of this PRISM grant and the website that I'm talking about. So I'll just show you a little bit, and we were hoping that we could actually get online and show it to you, but we're not going to be able to do that. But this is the website. There is going to be amazing information on this, lots of stuff about end of life. So yes, we also talk about end of life and how to manage cirrhosis care there. We had pharmacists on these panels, so about drug dosing and cirrhosis. There's going to be a lot of information there about that. And then all of these symptoms will be addressed. And what we've done, trying to make it simple for people, instead of doing a chart with 40 medications with all the ranges of doses, which is what normally we get, and we think, okay, great, it's going to be a couple of medications, what the recommended started dose is, what to look for side effects, etc. So we're really hoping that it can fine tune things for people. Just as I said, each patient is an individual, so really paying attention to who your patient is. Those goals of care discussions and advanced care planning is going to set you up for success with everything in your patient's care. It's not just about M, and this M is this massive continuum of care. You know, it goes all the way from barely going into the intensive care to, well, maybe I'll have antibiotic to help me live a little longer. So it's really important that we have those conversations, and we have some information about that on the website as well. There's lots of scales in there. So you can go in there when you go to the symptom, depression scales, sleepiness scales, lots of things that can help you kind of assess, like that ESAS score, where your patient sits. And it also has this OPQRST UV symptom assessment to just talk to you about how do we do a little better job assessing symptoms, because that is actually a lot of hard work. I spend a lot more time doing that than I used to, for sure. Here's an example. I pulled up the breathlessness one because it was easy to put on the slide, but it shows you shortness of breath that's episodic, that you don't need something all the time, a simple single recommendation. And then if it's longer term, it's not easy to just do a one-off as needed. Around the clock is always best. It talks to you about starting doses and small starting doses, 0.5 milligrams oral. As I said, Dr. Rashik would laugh, but I have been known to give 0.2 milligrams. The problem is when you start getting into doses like that, you have to make them into liquid formulations. The compounding pharmacies now in the community can do it. You have to know a compounding pharmacy, and it can be expensive if the patients can't draw it up and they have to have syringes. So there's a lot of things about that. If you don't want to get into that, no problem. That's why palliative care docs are available on the phone. Or pain specialists, they can help you figure it out if your patients don't tolerate these kind of medications. And that's when you might want to call somebody who's more specialized, if maybe these recommendations on the website aren't working very well for you. Here's a nice one for the breathlessness. We have some flow sheets like this as well that are easy to follow. So you can look at, well, wait a second, do I have to do something first before I treat someone for breathlessness? Do I have to think if they're anxious or not? And we try to give some guidelines about that. So there'll be a lot of great resources. I can't tell where my time is because I can't see anyone, but I'll just keep going. So the main takeaways: our cirrhosis patients want this information. They want to know about their health. They want to have the conversations. They're desperate for these conversations. They want to talk to you. They want you to know what they feel. Provide this palliative education early. Ask them if they want it and include all that advanced care planning. We'll send them home with that information, send them to the websites, let them go, think about it, absorb them, then maybe have some virtual clinics or something where you can start to talk to patients about that. I'd love to hear some comments in the comments about how people are doing that. I have given people lots of advice on how I sort of see things happening or how to integrate that into your practice. Always remember to talk to the patients that symptom care includes the social, the psychological, the spiritual, and physical components, and that the medications are not the first answer. The medications only work on receptors, and all those other components are so critical. And work together, all of us together, to overcome these barriers for our patients. I know that we are going to do an amazing job with this work. I have high hopes. And I really think picking up the phone and talking to each other is so, so critical. I hand out my cell phone here nor there. I think I have my email on the next page. I'm so happy to hear from anybody that has any questions. And I still answer phone calls from family docs from years ago from talks because they were wondering about something I had said or how to titrate opioids, for example, for breathlessness. So I just love to be connected with you, with all of you. So as I just wanted another special thanks to Dr. Tandon, because she's been such a great advocate for the cirrhosis patients. And just passionate for this work. And the more of us that can be like that, the better. And as I said, there's my email if anybody has any questions in the chat box.
Thanks, Amanda. As usual, that was brilliant. I just want to do a shout out. So we are super excited about the website launch, and we're actually going to do the website ribbon cutting and opening on March 16th, I believe we've decided. So everyone will get an email about that, and we'd love if you could join in for the celebration. And I also want to do a shout out to the PLP for designing a lot of those beautiful symptom management pages, especially Jordan Tate, who works there. So it's been a co-development and a very successful one. So with that, I want to introduce Dr. Ingrid de Kock. And Ingrid, you can turn on your camera if you haven't already. So Ingrid joined the Edmonton Zone Palliative Care Program in July 2000, and she completed her palliative care fellowship at the University of Ottawa. And previous to that, she had experience working as a rural GP surgeon and anesthetist after completing her medical training in South Africa. So she works within the Edmonton Zone Palliative Community Consult team, providing consult services to the community and acute care hospitals, hospices, and long-term care facilities. And her research focuses on clinical aspects of palliative care. She is the physician lead for the Palliative Community Consult team, and also the section chief palliative care, the clinical medical lead for the Edmonton Zone Palliative Care Program, and past president of the Canadian Society of Palliative Care Physicians. So welcome, Ingrid, as well to the panel. And I would encourage you guys to ask questions. One question, Amanda, that's come up from Dr. Nguyen is, a couple of my patients recently became palliative patients. In order to get Blue Cross coverage, you need to tick the box that they're expected to die within 3 months. How do we justify that if palliative is not the end of life? She's had a patient.
I have an answer for that. Ingrid, do you have an answer for that? I'll tell you what I did in my clinic, and then I'll let Ingrid add on. Yes, this is very frustrating. You know, a lot of our patients we don't know. And so with the chronic illness in palliative care in the literature, it says your patient, if you wouldn't be surprised that they might die in a year, you could actually justify ticking that box off. And I always walk around the medicine wards and go, I wouldn't be surprised if any of these patients would die within a year. So I tick it off that they're expected to die within 3 months. I tell the patient that I've had to do that. And if they come back at me, which actually they never had, so I've done this quite a bit, but if I have to redo it, I just redo it. And if they ever come back to me, I just write in there that this chronic illness is very unpredictable. They've got severe disease. They're very lucky to have survived. And I haven't been challenged on it to date. But Ingrid, do you have any other?
No, Amanda, you know what? I do it very much in the same way. I think a little bit case by case. Sometimes you do have a patient that you know they have a really great medical plan or whatever it is, that's a different story. But so many of the patients that we do encounter in that last year or 6 months or so of life really struggle financially. The burdens are just great. The family can't work and all those things. So I do the same thing. I tick off the box. And again, the same, in 20 years, nobody's ever come back and asked me about it. So far, so good.
Okay, excellent. Dr. Van Zanten actually has a question, and I'll just read it out of the panelist side. So he's asking about whether or not for patients with higher MELD scores, there's a one-page document that can document the extent of end-of-life discussions that have taken place when they get admitted, or a page attached to the personal directive that summarizes the discussions on end-of-life care. Now, is that the green sleeve, Amanda and Ingrid?
It's the tracking record. So, and it's funny because that ACCEPT study that I talked to you about, there's actually a tracking record that's supposed to go in the back of the goals of care, the green sleeve, and it has like a progress note where you're supposed to write everything that's been said down. And the uptake in Alberta was almost nothing, actually. So we do have a lot of work to do with that. But if you do use that tracking record and put it in the back, it's supposed to go to the primary care doc, and then they look at it and they say, oh, this is what Dr. Brisebois talked about. We just did this for a patient we discharged from the palliative unit. So that's probably the best place to do it because that's where the ambulance looks as well. Ingrid, any thoughts on that?
Yeah, I do think, I've just looked at our participants, and I'm sure that there are some from other provinces. So we're lucky in that we have the green sleeve with the tracking. Yeah. Unfortunately, you are right. We're not very good at doing that tracking sheet. But when we do, it's extremely helpful document. But I think in other provinces, depending on what kind of EMR you have, that might be the best place to do it. We now have Connect Care, and I do think Epic. I do think a lot of these notes will be duplicated perhaps, or we might not do the tracking sheet and it might just sit in Connect Care. So I think one has to be a little, you have to really think outside the box and see where you can do it. I've heard in other countries, even people carrying a little card, a patient self having a card that says where they are at. And I've never seen one of those, so I'm not quite sure how much tracking there is. But I think we have to think outside the box. How can we make this work for patients?
Absolutely. And I always say to dictate it and to put it in your consult notes too, because that's so important. And then if whoever's reading it doesn't understand, they can pick up the phone. A lot of primary care docs have said to me, I don't want to have the conversations because I'm not a hepatologist. And so maybe they can call the hepatologist and they can have a conversation.
And that's a question that's come up in the panelist box as well, is around, perhaps as a family physician not seeing these conditions that often, that prognostication discussion is even challenging for us hepatologists who see them. So what do they do in that? So how do we work together as a team in that? I think it's such a big topic. What do you think, Amanda?
Well, I pick up the phone. So I do a lot of picking up the phone to the cancer docs. I do a lot of picking up the phone to let's say I have a patient of yours, Panita, and they're in hospital. I would phone you and say, hey, look, this is my instinct. This is what I've done looking at the MELD score. You can actually go online and look at the prognosis based on the scores, but that's just numbers. And so someone who's known the patient for a long time, ask the hepatologist what they think. You can look at the numbers. I had a cardiology patient once. I did that with the Seattle Heart Failure Index, and he wanted to know, and I plugged in all his numbers, and it said 80% 5-year survival. And he said to me, that's crap. I'm not going to live for months. He said, I'm not going to live. And he died 3 months later. So it's very interesting. There's a bunch of prognostic scores in the last week that we can use, but I think it's really picking up the phone, talk to the palliative docs. Like, we're all trained in that. There's someone on call. If you really want to prognosticate, ask us how we do it. I think that's a good start. Ingrid, do you have any other suggestions?
No, do much the same as you do. Amanda, you've got all the palliative care principles down so pat that you work like a palliative care physician, and you are one. So yeah, no, I haven't got anything to add there.
Love working with Ingrid.
Okay, question around, and Amanda, I love your languaging when we're talking around medical care, comfort care, resuscitative. So sometimes Dr. Randhawa was saying it's really difficult to start that goals of care change discussion from medical to comfort care. Any tips for how to do that?
Yeah, well, there's really the one key difference is that they want to try to live longer. Like, they're valuing in medical care, they're valuing their life right now. They have something to live for. They want to prolong their life. And there is a shift in everybody's life where you get to a point where you're suffering in some way, you're not finding value. Maybe you can't get out of bed. Maybe you have some symptom that's very concerning to you, don't want to live with. So I really ask them, is your goal to live longer, or is your goal to be as comfortable for however long that life is going to afford you and this illness is going to afford you? And actually, they usually can answer that question. We can do tons of care in the comfort piece that's exactly the same as the medical piece. Like I've been known to treat pneumonias on the comfort piece because they're so symptomatic and they just want to feel a little better. So they really overlap quite a bit, but I really try to focus on what their goals are and bring it up as a goal-oriented conversation rather than what I'm going to do to you kind of conversation. Any other comments from you, Ingrid?
You know, Amanda, no, I think that is excellent. I also like using that graph that you have. I often use it because I think the timing of those discussions from medical to comfort, you have to time it right. You know, I can't just, when a patient is on that graph is at the top of one of those cycles, that might not be the right time to be having the discussion. But when they dip down and they already know what they've gone through, and perhaps it, as you've said earlier, you know, they don't bounce back to where they were, that is a good time to talk to them about it. And again, I think in our own minds, we have to have a good idea what comfort care is, because I still come across people who think comfort care means withdrawal of everything, and all you do is you give your patients morphine or hydromorphine or whatever it is.
I'm so glad you mentioned that. Yeah.
And
such a big misconception.
So much more. It's really quite aggressive treatment or management. You know, for cancer patient, if they have a spinal cord compression and they're in a lot of pain, I'm picking up the phone and I'm sending that person for an MRI today. So whether they, you know, if they're in the comfort care or medical category, because we know that if we then get some treatment, radiation to them, we can actually manage pain. So I always say to them, when we talk about comfort care, it is anything that will make you feel better. It might not be anything that is going to make you live longer, but it is anything that we can possibly do to make you feel better. That's comfort care.
It's beautiful. I've done splenic embolizations on people for comfort care because they wanted to make the birth of a baby, but they were still really didn't want to, you know, focus on living longer, whatever it may be. They didn't want to bleed to death. So there's a lot of things. Yeah, the graph can be really, really useful. But when I talk about that graph, so Ingrid, thank you for bringing that up. I say you get aggressive care from the day you're born to the day you die. It's just the care that is going to help you live the life you want. And that you can live, like what will actually help you. I'll use examples, for examples, ascites or transfusions. They will be able to tell you the day the transfusion no longer helps them. They will be able to tell you the day the TAPS no longer helps them, no longer relieve their symptoms. And so the patients can really be involved in those discussions. And I've had many patients go, remember you told me the transfusions wouldn't make me feel better at a certain point? It's today. So it really empowers patients to give them that information ahead of time so that they can be a part of it.
Beautiful. I love listening to you both talk. Question around, and this I think will be brought up next week, but around the dose of hydromorphone in patients who have hepatic encephalopathy. Are you more cautious about that? What do you think?
I desperately want to answer this because I know Safie's going to say something different. I wish he was on the line. Safie and I love bugging each other, but it's okay because I always say, how sick are the patients? Look, if I had a patient in the hospital or an outpatient who had hepatic encephalopathy, I would be giving them a liquid formulation. That's just the way I work. Like I would be giving them 0.2 milligrams liquid. You put it under the tongue. They just let it sit there. I give it before bed so that if it has bad consequences or it's too much, they get up in the morning, they call me, tell me how they were, and they can either say they tolerated it or not, because opioids obviously can make it worse. So I really start with tiny doses, and if they do well with the tiny dose, then I increase the dose to twice a day and I let it sit until they have no side effects. And if they do well, then I increase it to 3 times a day. Safie may say, look, that's really complicated. Why give liquid? Why don't you just give them a 0.5 or try to cut it into a quarter? Because I've seen that, you know, why don't you try to cut the 1 milligram tablet into a quarter and just give them, look at Ingrid, I hope you come to next week. But yeah, you can just start a tiny little dose and that's what I would do. I don't tend to give 0.5 milligrams, to be honest. I just find it too much for patients when they're encephalopathic. Ingrid, do you have comments?
I agree. You know, I don't know if any of you have ever tried to cut one of those 1 milligram.
It's brutal. Yeah.
You can still get to a half with fair accuracy, but it usually crumbles. And so, you know, you never know exactly how much the patient will take if you tell them to cut it into quarters. I agree. I go with liquid morphine in that situation. If the patient is severely encephalopathic and they are obtunded and you can't, you know, they're not swallowing reliably, then we will usually go to sub-Q. And again, it's a tiny dose. We might start with 0.1 milligram of hydromorphone and titrate more carefully than we would normally. You know, in a patient that doesn't have a liver impairment, we would say, well, count over 24 hours how much they need if you have the patient on around the clock opioids, and then add it in. With these patients, we will perhaps add in half. So we just really, really go slow and go low.
Yeah, and I have a beautiful titration chart I use for my clinic for outpatients. Anyone just take my email, I can always send it, because they keep track of their symptoms before and after and how to titrate it and stuff like that.
We can put it up on the website too. Okay, so from one of our family doctors, Dr. Abeltive, it's a completely different chemistry to discuss goals of care for someone going for surgery versus someone with a terminal illness. And it seems that patients are perhaps not content to have their discussion with just a family doctor and they request to talk to the specialist. Any thoughts to help patients and family doctors steer the discussion in the right direction?
Well, I think if they're asking to talk to their specialist, I think it's very important that they do get to talk to their specialist too. But I think the family physician can say, yeah, I understand why you want to hear it from them as well. How about in Australia, when I did a sabbatical there, they did case conferences. So they had the family doc, the specialist, and the patient. So there's lots of opportunities, especially now that we have this virtual care, that you can actually get the specialist involved. But I really think having the conversation with the specialist, yourself as a primary doc, the more we ask, then Panita, you can tell me what you think, but if some primary doc calls you and say, hey, I really need this conversation with the patient, can you help me? That drives specialists also to realize how important it is. So that's what I would do. I would just explain to the patient that you appreciate that it's useful conversation. Even if you don't know what the prognosis is, talk to the specialist, see what they use, talk to palliative care. If you think you need some prognosticating tools, we're happy to give them.
Yeah, it is a team game. And, you know, we are, just speaking for hepatologists, we're uncomfortable with a lot of things that family physicians are very comfortable with and opposite. So if we work together on this, I think it'll be much stronger for the patient.
I would like to give a little plug for the community palliative care team, because when you do have people end of life and last months, Ingrid's team in the community can go in and help support people in the home as well if they have severe symptoms, etc. So that resource is available. We're very lucky to have it.
Yeah, and some of our patients have availed of that and really helped so much. Ingrid, perhaps to you, another question about, do we have to wait until the patient is goals of care compassionate to do palliative care consultation?
No, please don't. You know, we're pushing very hard at the moment. Palliative care came from the cancer world and then expanded into non-cancer. And I think the next big thing is going to be expanding into early palliative care. We really are suggesting that old idea of palliative care being end of life care, the last month or 2 or 3 months of life, that has had its time. It's over and done with. I think there are so many studies that show that involving palliative care or doing palliative care, having a palliative care approach early on is great. Tomorrow, I'm actually going to see a patient who is R1. I'm here in Alberta, so resuscitation, the full meal deal, but he has a lot of symptoms and he's just not quite ready yet to make that transition over into more medical care. He's going to need time, and that's fine. But in the meantime, I can do something about his pain. So please do not hesitate. If anything, if I may put a plug in for that, get palliative care involved as early as is feasible. I know that it is sometimes difficult for patients early on in their disease when you say, look, I'm calling in the palliative care doctor now, or the palliative care team because there is still that perception that palliative care, it's a bad word, and it means you're dying. So you have to, first of all, just clean that up for the patient, educate them and the family about that. And then please get us involved. We are more than happy to come in year 2, 3, 4 years before a person's death.
Perfect. I'll just take a couple more minutes of your time, everybody's time, to answer a few more questions. They're really good. MAID requests. Are we getting MAID requests in the context of end-stage cirrhosis?
Ingrid, because from my perspective, not much.
And this is just perception. I can't say that we've really looked at the numbers.
Yeah, I can't.
I have the same idea. It's no more or no less than it is for other patients. But we do get the occasional request when we see somebody really at the very, in that last phase, the last month or two. Sometimes they do ask about it, but not more common than usual.
And I have to say that the cognition thing is a real problem with the cirrhosis patients, because when you're encephalopathic, which they often are, they're no longer candidates. So that, I think that's a confounding factor.
Yeah, fair enough. And then on that same line, do we think patients considering MAID should get a palliative care referral first to ensure their symptoms are managed first? I wonder if that's part of the protocol.
It is part of the process that they need to have talked. There's a whole process, but they need to know their options, etc. And
okay, yeah. And then Noosh, who's one of our partners.
Hi Noosh, thank you for all your work.
Noosh is mentioning that we use the term supportive care for involving palliative care at an earlier trajectory of illness, and yeah, I think that's what we found handy for some of our patients as well. And then the last couple questions, how to gain access to the website. So we're going to have a big party here on March 16th online, and we will release the lock to the website at that point. And then there's a very kind doctor from Egypt, Amanda, who would love to collaborate with you on research. Oh, and one more question, I think. Pressure ulcers. We'll end on pressure ulcers. So I'd like to understand, for pressure ulcers, if wound care with a wound vac is not part of palliative care. I was told only to dress. You guys would do wound management as well as part of palliative care?
Well, I had a patient with a wound vac in the hospital, but honestly, they're quite aggressive. Like we did have somebody with one, so I wouldn't say I would never do it, but in general, I wouldn't tend to. There's a lot of other ways to symptom manage a pressure ulcer. Depends on the prognosis, obviously, but I would tend to avoid them. Ingrid, do you use those much?
I will, certainly on occasion, I will ask for the wound care team to come in, get the experts in, because I'm not an expert at wound care. And we have had the occasional patient who actually qualified for a wound vac. And I remember one particular patient that I was really impressed. I thought it worked so well.
Yeah, I wouldn't rule it out just because they're palliative care. This is the whole, you can have pretty aggressive care. So if that's their main concern and it's causing pain and the wound vac might improve their pain, absolutely it should be considered.
Okay, bottom line, it's all about symptom management and improving quality of life.
Yeah.
So thank you both. And thank you to the PLP for organizing this.
Thank you, everybody.
Lots of work behind the scenes to get this going. And thank you for everybody who came. And we're looking forward to the final lecture next week. So
everyone go to that, because SAFE's great, and I'm going to go just to ask questions.
Okay, take care, everybody.
Bye, everyone.
Thank you so much.
Thanks for coming. Thanks, Ingrid and Panita.
Goodbye. Great talk, Amanda.
Yeah, lovely talk, Amanda.
Bye.
Bye, Panita.